early, so probably we'll have a question and answers at the end of our talk for her. Dr. Mayank Aggarwal will stay with us. We can have the question and answer later on with him. So, Dr. Gogia, please, all yours.
Thank you so much. Thanks. Thank you, South Delhi Physician Forum, for this kind invitation and opportunity. It's a very warm welcome by you and by Sir introducing us individually to all of you. I have next 15 minutes I will be focusing on what I like or what I love to do as a professional. I'm a pulmonologist, and the edge where I can make a difference are few of the techniques and technologies which we use to make a diagnosis, and a confirmed diagnosis we all know gives us more confidence in treating the patient, prognosticating the patient and taking it forward. So the history starts from year 1887 when a German surgeon, ENT surgeon, took a, can I have a pointer please? So he is using a steel rod known as rigid bronchoscope to take out the foreign body from the throat of a farmer, and that was the beginning of intervention pulmonology. This man is Shigeru Ikeda. He is a Japanese scientist who in 1987 invented this flexible bronchoscope. And after that, we have several technologies which have been added. Here what we see is a radial EBUS. We have introduced ultrasound into the lung with the help of a thin probe, which is a 2 mm probe. This is a conventional probe EBUS. So this is our modified bronchoscope with a tip, and this is a needle which under the ultrasound guidance enters the lymph nodes or tumors which surround the central airway. Here what we see is a thoracoscope. Somebody was talking about VATS, but here what we do when we are not able to diagnose the cause of pleural effusion, we put our thoracoscope, flexi-rigid thoracoscope, into the pleural space and take pleural biopsies from parietal pleura. And nowadays, this is we are repurposing the old drugs, so we are rediscovering the rigid bronchoscope, and I am trained in all of these modalities and we use it often. We have lots of, we have all these in our hospital and we use all of these tools often, and we are a busy IP center in Dwarka or in Delhi. So I will take you along this journey through few of the interesting cases. So all that wheezes, and we call it very easily, we call it asthma, not so with children. So one 11-month-old child with history of constant barking cough for 3 days, fever for 3 days, allergic choking on nuts, tachypneic, tachycardic, decreased air entry on the left side, X-ray chest. So this was kind of the X-ray chest. And what we did, so on bronchoscopy, this was the picture. We can see a groundnut. This is a Dovia basket. We have put it through a flexible bronchoscope. We are catching the foreign body and we are taking it out. So that was the carina and this. So that's how we usually, every winter season, I don't know, the winter season is the season of eating nuts, and we get 4 or 5 such cases. There is a blood clot which is acting as a foreign body, and we are using a Bugatti balloon to take that clot out. So this is a Bugatti balloon. We have inflated the balloon, and with balloon we are pulling that clot out of the left main bronchus. And this is a recent foreign body which we have taken out. Past week we have 2 children One was 1.5-year-old and another was 3 years old, both with a groundnut, and we have a new tool in our armamentarium which is a cryo probe. So it freezes, cryo means freezing, so it freezes the water. Look at it, how the ice is formed between the probe and the foreign body, and we are pulling it out. So within no time the groundnut was out. So now there is another cause of wheezes. It was not in a child, it was a 34-year-old lady presented with respiratory distress and audible wheeze, stridor in the ER, immediately intubated and put on ventilator, no previous history of bronchial asthma. So it was very difficult to believe that at 34 years for the first time she is presenting with symptoms mimicking bronchial asthma. In the morning when I came for my rounds, I was told that she has acute severe asthma. And on probing, we found out that she has history of recent intubation and mechanical ventilation 2 months back because of road traffic accident. And that helped us to make a diagnosis. I immediately thought it cannot be bronchial asthma, it has to be a tracheal stenosis or a stricture. And that's when we extubated, we do a bronchoscopy, and what we found is a tracheal stricture. So even if a patient is intubated even for 1 day, that is good enough to cause a tracheal stricture or stenosis. So when you feel that your asthma is not getting better with your routine bronchodilators, think of these things, think out of the box, and we might help. Look, I'm using a cautery knife and I'm giving an incision into that tracheal stricture. So this is a cautery knife. We are giving an incision. We'll give a Mercedes. We give 3 incisions into that stricture, and then we dilate it using this balloon. This is known as CRE balloon. Sometimes one sitting is enough, and sometimes we have to call patient every 2 to 4 weeks and do this balloon dilatation, serial balloon dilatation repeatedly. This is a case of pleural effusion which was undiagnosed. A 75-year-old male, Chennai, breathlessness for 1 month, edema for 1 month, ill health for almost 1.5 months. And he had worked in a foundry for several years. He had pleural tuberculosis in 2018, and which was fully treated. Routine investigations were normal, echo was normal, and this was the X-ray. So all of you will agree with me that he has a right-sided pleural effusion. So what should be our next step? So we aspirated, yes, somebody has said drain the fluid. We drained it, we did a diagnostic aspiration, 1800 cells, mainly lymphocytic. ADA was not high, it was normal. LDH was also normal, malignant cytology, negative for any malignant cells. Here I would like to ask, what should be our next possible step? So we thought what it could be. It could be tuberculosis relapse. Patient had taken though ETT, but TB can always relapse. Malignant effusion with unknown primary. Maybe it's not tuberculosis. He's 75 years old. There is a primary, hidden primary, and we don't know. And the fluid is part of the malignancy or the
not high. ADA was not high. That means it's not tuberculosis.
ADA has a very high specificity, and though the sensitivity is low, so it has a very high negative predictive value. So if ADA is normal, there is very less chances that it can be tuberculosis. Mesothelioma in view of occupational history of working with a foundry. So that's how we were thinking that what should be the next. We did a PET scan. This is the PET image with effusion, no other hotspot or no other FDG-avid lesion in the PET. And then we thought of medical thoracoscopy. Medical thoracoscopy is a flexi-rigid scope, patient in right up, left lateral position, under sedation and local anesthesia. We know most of our thoracoscopies we do in our bronchoscopy suite, not under GA but under sedation and local anesthesia. And flexi-rigid scope was introduced, pleural fluid was aspirated, pleural surface was examined, examined a few sago grain-like lesions, biopsy was taken, and that's what we saw when we entered the pleural space. So these were the lesions. We took biopsies from them under vision. So gone are the era of blind pleural biopsies. Now we do under vision. These are the sago-like lesions. And this is what we found. Pleural biopsy suggestive of lymphoproliferative disease of pleura extrabronchial lymphomatoid granulomatosis, which is B cell rich. It is a rare disease, a rare lymphoproliferative disorder. And just to make it, then we had another case, a 50-year-old male smoker presented with breathless NOPT, sign and symptoms suggestive of COPD. And like any other COPD patient and smoker, we do an X-ray chest. A left upper lobe mass lesion was seen. So here is the suspicious lesion. And we did a CT. We find a well-defined lesion which is not touching the pleura. In bronchoscopy, the patient, by the time has presented, he had got a bronchoscopy done outside, which has showed, bronchial biopsy showed a few atypical cells or dysplastic cells. So we wanted our attempt to be better than the previous attempt, so we get a decent sample. And we have, this was the PET. And so we choose our tool as radial EBUS. So this is the disease mucosa. We identified the segment where the mass is. So this is a radial probe. We are checking in which segment is the mass. So this radial probe has an ultrasound here, which is connected to an ultrasound transducer. And now this is the bronchial view and this is the ultrasonic view. So this image shows a mass lesion in this segment, and we measure, we fix our scope at that point where we see the mass lesion, and we take biopsies at this point. Sometimes we do take cryobiopsies, so we get a bigger piece and the biopsy can go for IHC and NGS, because without that Mayank will not treat the patient. So Mayank is very demanding, he needs lots of tissue, and tissue has always been an issue, and these tools or these modalities helps us to get the tissue, adequate tissue in a single test. So here we have seen the mass. We go take a biopsy forceps and take biopsies from this area. So we found a non-small cell adenoCA. These markers were advised. TTF1 was positive, making it a CA lung, adeno-CA lung, and then Mayank took it over. Then we have another tool. This is a common scenario you must be facing in your OPDs with mediastinal lymph nodes. And how do we sample mediastinal lymph nodes? We use convex probe EBUS. So this is the EBUS under ultrasound guidance. The needle is going inside this lymph node. We are taking the sample. We take the sample for gene expert, cytology, cell block, and our yield is almost 90%, as good as any well-renowned international center. So this shows a granuloma with caseation. It was probably tubercular. And then we do electrocautery, we debulk tumors, central tumors. This is a therapeutic modality. So this is a cautery probe. We are burning the tumor. And we are seeing whether the tumor is vascular or not. And in the next, this is a cautery snare. So we, at the neck of the tumor, we hold it with a cautery snare and we give current, we coagulate and cut, and we en bloc take the tumor out. So this is a snare which is holding the tumor. Look, this wire, this is a snare, it is like a loop. So we have looped the tumor and we cut and train, and with the forceps we hold the tumor and bring it out, and it's immediately open the central airways. So these are few of the things which I have shown you, and recently we put all type of stents, self-expanding metallic or silicone stents in benign and malignant tracheal strictures and stenosis. So we do all these things. That's my presentation is all about. I've tried to cover all the modalities which can help you in making a firm diagnosis. And this tumor debulking and stenting is a palliative modalities. And when we do the medical thoracoscopy, we sometimes do the talc fluorodesis. We are putting IPC, indwelling pleural catheters, in stage 4 diseases with pleural effusions. So thank you for the patient hearing, and you can ask me questions. I request you to put your questions to me now, because I'm sorry, I'll be leaving now.
No problem, ma'am. We will not leave you without questions. You can be leaving, but we are not going to leave you without questions. Ma'am, you showed a case of pleural tumor, which we initially thought was a recurrence of tuberculosis. And the pleural biopsy showed the
Lymphoproliferative disorders.
What would be the prognosis of this patient? I wanted to ask.
This is a rare lymphoproliferative disorders, has to be managed like with chemotherapy or a part of spectrum of lymphoma, and sometimes it depends on the functional status of the patient. If he can tolerate the chemotherapy, the prognosis is good, it can be controlled. If he cannot, his functional status is poor, then it's a progressive disease.
What was his prognosis?
He's 75-year-old. He did better with chemotherapy. He's a walking South Indian gentleman. His functional status was good, so he did well with treatment.
Okay. Suppose, ma'am, it was mesothelioma, and when I was doing my MD in '86, I came to learn that mesothelioma has a very poor prognosis. Has the prognosis changed over the years?
Yes. I think it is not so bleak as it used to be when the time you are talking about. I think Mayank has treated 2 or 3 of our cases of mesothelioma. They did initially good, 8 to 10 months. After that, one of them, he was a relatively young gentleman, 57-year-old. He passed away because surgical options is limited and medical options are limited. It is chemo, sometimes it is radiation is not an option. Chemo resistance also develops in due course of time. So mesothelioma still has a bad prognosis.
Ma'am, unfortunately, I remember a case from 1986, a 22-year-old guy, young guy, who had a mesothelioma, and he perished very quickly. Dr. Mayank, has things changed for young mesotheliomas?
Mesothelioma, we do not have much of sorry. So, in thoracic oncology, mesotheliomas are still considered very bad, and especially those who are unresectable, because these are generally disseminated and involving entire pleura and most of the parts of the pleura. And we do not have very good surgical advancements in these patients as well. We have to go for pneumonectomies, and patients generally do not do good. And chemotherapy regimens have also not changed much over the time. Yes, by the kind of this molecular oncology, we have got some better responses. But if I say in general or overall, I don't think mesotheliomas have done. Over the years, we do not have much of improvement in the treatment of mesotheliomas.
The pain is terrific in mesothelioma.
Yes.
It leads to suicide also.
Yes. In cases the pleura becomes so thick, in cases the lung, the patient has impending sense of breathlessness despite of the involvement is not, it's the pleura that does not let the lung expand. So that's an impending sense of breathlessness all the time.
So, apart from oncology, apart from therapeutic advancements, we have a lot of supportive care advancements, and pain management and supportive care have got much better over the years. And to be very frank, when we talk about progression-free survivals and overall survival, supportive care actually plays a very vital role. And because earlier we used to have a very huge number of dropouts from the treatment, just because the ongoing side effect management used to be very bad, right? But nowadays, with our pre-medications and everything, first of all, these side effects are very getting less frequent, and they are very easily manageable. So we have this palliative oncology thing. The patients who those who are not fit for anti-cancer therapies, surgery or radiotherapy, we generally take these patients for a treatment that we call it as best supportive care, right? And we give all sort of it's all palliative and symptomatic management. We have very good opioids in the form of transdermal patches, with which we can actually control pain for a very good time.
One small question, do you do intrabronchial valves for emphysema?
Intrabronchial valves are not approved in India, so yet we are looking valves and coils to be approved in India. Though the valves and coils are standard of care in USA for past almost more than 5 years, and in Europe they have been using it for more than 10 years. When I went for my fellowship at Royal Brompton, that time they were approved in Europe, but we are waiting because I think it's more of an issue of misuse, like cardiac stents. So that is the reason that valves are not being approved in Indian.
Dr. Tulsi sir.
So, great cases you showed, Dr. Gogia. So, do you have robotic bronchoscopy in your center?
No.
Does it have any edge over the conventional bronchoscopy?
Yeah, we have conventional bronchoscopy. We don't have robotic bronchoscopy. It's a dream I nurture that maybe we will be the first center to have a robotic bronchoscopy.
Okay, Dr. my last question will be regarding the bronchial thermoplasty. So, are you doing this at your center for severe, uncontrolled bronchial asthma, or in patients who have bronchial valves for emphysema?
The bronchial thermoplasty went into disuse 3 years back because it has been seen that it is not cost effective. The thermoplasty wire which was supplied by Cook, it used to cost us around 3 lakh rupees, and the cost benefit ratio was not
cost effective.
Not cost.
Right,
So
thank
now
you.
that wire has come, it's
Right.
no more available.
Thank you.
Dr. Kanda sir.
Lithotripsy is coming big way everywhere. Even intravascular, we are doing lithotripsy. Is lithotripsy also done intrabronchial bronchoscopically?
No, we don't have.
Not yet.
Not adopted. Maybe that's a good idea. We can think of adopting.
Well, nuts are seasonal, as you said, that there is a season for nuts, so the foreign body. The chewing gums are every time. So how frequently you see chewing gums as a foreign body blocking the...
I have seen the most bizarre foreign bodies. We have published almost 400 foreign bodies we have taken out. The most bizarre was a steel ball with a steel chadra which goes inside. And every time we put it, it will slip back. And then we had to take 2 strong magnets to pull it out from externally. We had to this thing, but we haven't seen, once we have seen chewing gum, once I have seen a wrapper of a medicine which a child took inside, so the silver wrapper. So,
Well, my last question about tracheal stenosis. Are there any stents or dilators?
if the tracheal stenosis is a benign stenosis like I showed after a ET tube, the cuff pressure of the ET tube has to be adequate. If it is more than 25 millimeter of mercury or 25 centimeter of water, the capillaries get blocked and that area of the trachea does not get the blood supply, causing it to stenose or stricture. So that is the role of an ICU, that we need to measure the cuff pressures of the ET tube. So even if you kept for benign strictures, we have silicone stents, and for the malignant strictures, we use self-expanding metallic stents. Silicone stents, we usually leave them at the site of stricture for 6 to 9 months, and after 9 months, we remove them under rigid bronchoscope.
Thank you.
Dr. No question? All right, ma'am. Yeah, Dr. Soeaker sir, आपने इज्जत रखी सर, उसके लिए बहुत शुक्रिया सर.
Ma'am, I'm a pediatrician. We used to see a lot of vegetable foreign bodies, especially peanuts. And in our time when we did our post-graduation and registrarship, we used to have only, solid bronchoscopes, not the, flexible type of bronchoscopes. So what is the current situation regarding foreign body removal with those rigid bronchoscopes as compared to those fiber optic ones?
Look, the rigid bronchoscopy is at the apex of the pyramid. So if I get 100 foreign bodies, I remove 90 with my flexible scope. But the difficult ones, my rigid bronchoscope is always ready while I am removing a foreign body with my flexible bronchoscope. If I fail with my flexible bronchoscope, I immediately convert, take the patient in GO and put a rigid bronchoscope and take out the foreign body.
So flexible bronchoscope is the rule of the day, because in our time they said flexible will not work because
No,
it won't go
I
in.
think that's how the science has progressed over few years. One of my mentors, Dr. Atul Mehta, says practically all foreign bodies I can remove with flexible. But we, as we know since we have the skill in both of them, so most of them I remove with flexible. But if I fail, I take help of rigid bronchoscope.
Thank you.
Sure. Ma'am, another pediatrician, celebrated pediatrician. Pediatric gastroenterologist. He also has a scope and he will have a question.
Just wanted to ask you, because we've tried to use pediatric bronchoscopes to do pediatric endoscopy in very young infants.
Yeah, exactly.
But one of the limitations is that the pediatric bronchoscope probably moves in 2 planes, whereas the pediatric endoscope moves in 4 planes. Am I right?
Yeah, true. Look, all of our interventions we have adopted from gastro only.
Because in my earlier years, I failed in trying to do a pediatric endoscopy in a 2-month-old or 3-month-old child, where facilities were available. But I could not do it because the scope could not move.
Right. Actually, my first foreign body I removed from esophagus. It was a point. He was a poor child. I went into the trachea, there was no foreign body. So my technician said, "Ma'am, why don't you go into the esophagus and remove it?" So I said, "Okay, let's try." He said, "He doesn't have money, he heavily paid to the gastro guy."
You can use pediatric bronchoscope, but please do not call yourself a pediatric pulmonologist.
Yes, please. Don't do that.
You can use, no
So
problem.
I removed the point from esophagus. We don't have a insufflator, so we use a 50 cc syringe to insufflate the air, so we can move forward.
Ma'am, wonderful skill set. We are really impressed. But we feel that there is more. ये दिल मांगे more. तो एक CME और करेंगे मैम 4-5 महीने के बाद. ठीक है? Thank you very much. Thanks a lot. Over to my second talk, and I request Dr. Sunil Kapoor sir to introduce our second speaker and to set the context.
Hello everyone. So we've been meeting week after week every Wednesday to learn something new, to enhance our knowledge about the field we are in. And what is all this based on? This is all based on research. And what is research? It is finding answers to the questions which have the assumptions, or finding questions for the things we take for granted. So with the research, we find all monoclonal antibodies, IVs, Deftinib and all these things. So besides another modality which has come up for cancer treatment and other similar treatments is this biologicals. So we got Dr. Mayank. He'll be telling us more about the cancer part of the solid organ cancers. And
Thank you, sir.
Thank you. Thank you for giving me this opportunity. So, I would say intervention people always feel the thunder, and my thunder. They should always be given, second talk slot, because being a physician, I don't have those such beautiful videos and so many instruments to show you. But to be true, having a good interventionist at your center is an asset. And in today's era, so what I'm going to talk today is that, so 16 years back when I entered my MD course, that time the diagnosis of lung cancer used to be like, the biopsy report used to say small cell lung cancer, biopsy is suggestive of NSCLC, and the other sort of report used to be biopsy suggestive of small cell lung cancer. That is all. That used to be the complete diagnosis. Right now, when I'm standing in front of you, diagnosis of NSCLC is a topic, is a very incomplete diagnosis, and we need to know much more, beyond that. What sort of cancer it is, what sort of molecular markers does it harbor, what sort of mutations does it harbor. Because each and every detail actually tells me, each and every detail actually helps me decide my treatment. And to get such an extensive examination, I actually need, oncologists actually need good amount of tissue. So unless and until you have a very good interventionist at your center, and FNACs are, for me, FNAC is nothing. FNAC, whether it comes positive, whether it comes negative, right? It does not stand anything to me. So it took me quite a long time to convince my other department seniors and my colleagues that I do not want any FNACs anymore, and please don't stop doing FNACs from to prove cancer. Today, if you have a mass and you're doing FNAC, if it comes negative, will you be actually satisfied with the result? No. 50% of the FNACs will say hemorrhagic fluid, atypical cells, right? And a patient with a frank, on clinical grounds, on scans, you're seeing that there's a huge mass, there are multiple nodes. You're certainly sure that this is tumor, this is cancer, right? And your FNAC is saying atypical cells suggestive of query malignancy, right? This is something which I am not able to treat. It is illegal to treat such patients. And so unless and until you have, so right now we have very sort of presentations. We get tumors at such locations where neither the bronchoscope can reach nor a CT guided needle can reach. In such cases, so we recently got biopsy, cryobiopsy. So I heard it for the first time 2 months back, and we got a biopsy from such a site. It was a wonderful biopsy. It was a positive biopsy. We got a good tissue. We got a radial. So whenever I meet Dr. Pratibha, she tells me something new. Radial biopsy. I said, what is radial biopsy? And so I also saw it for the first time. How is it done? But she told me in theory that we go in a radial manner. We identify the tumor with the help of an ultrasound. So there used to be, the EBUS guided FNAC, what it used to be, we used to go straight, you put a needle, come out. But in radial you go basically in a 90-degree sort of a thing. It's actually very easy to say, but it's very difficult to do. Because for an intervention radiologist, right, you can imagine for an intervention radiologist who is getting a biopsy from the surface of the body, many times it is very challenging for them to get a biopsy. And you just imagine how difficult or how precise you must need to be to get a bronchoscope inside. First you put your bronchoscope inside, do an ultrasound, and then identify a site, go radially and get a biopsy. Right? So having a good interventionist, having a good interdepartmental communication is very, very important. And I'm here in Venkateshwar since last 3 years. One thing which I would like to say, most of my seniors, my colleagues in other departments, they are very, very supportive. So I'm not that senior, but whenever I go to them and tell them, sir, isko aise nahi aise karna hai, I want this, they actually listen it very, so medical college की तो हमारी habit है ना, professor के पास जाने से डर लगता है, जाओ तो कहता है who are you to tell me, right? But here, so this is something good in corporates and private. People listen to you, they listen what do you want, why do you want it. If you know the reason, then I'm blessed that I get such seniors, I get such colleagues who actually give me what I desire. So going forward, as I said, right now lung cancer is not just one size fits all. One size fits all solution. Having a diagnosis of CA lung is not enough. Right? Why is it so? Okay, so the topic for today's presentation is advancements, right? So there are two advancements. आपने नाम सुना होगा targeted therapy and immunotherapy. बहुत fashionable नाम है. Immunotherapy बहुत महंगी थेरेपी होती है. Targeted therapy भी बहुत महंगी होती है. So I will be telling you in summary what these therapies are, and after that I will show only one slide and I will finish it off. Targeted therapies is, first of all, we try to find the target if it is present in the tumor. So first of all, it is not mandatory कि हर tumor के अंदर हमें कोई target मिले, right? So in Asian population, we say it is somewhere around 40 to 45% in which we might get targets. In European and Americans, this number is even low. So it is somewhere around 15 to 20%. But in Asians, we have a probability of getting a target in 40 to 45% of patients. Now what these targets are? So we all know that cancer originates from accumulation of different genetic mutations, right? उन्हीं genetic mutations में हम oncogenic driver ढूंढते हैं. So our scientific team, जो हमारी scientists बैठे हैं जो all over world, those who are studying the biology of the disease, they have identified oncogenic drivers, the main mutation which is responsible for cancer growth. So we have identified a list of such oncogenic drivers, but we have medication for few of them only. Right? हमारे पास सबके लिए मेडिसिन नहीं है, लेकिन बहुत सारे ऐसे हैं जिसके लिए हमारे पास मेडिसिन हैं. जो मैं 40 to 45% बता रहा हूँ, ये वो वाले हैं जिनके लिए हमारे पास दवाई है. देखो म्यूटेशन तो 100% पेशेंट्स में मिलेगी, क्योंकि कैंसर होता ही म्यूटेशन की वजह से. There is no other mechanism of biology behind the cancer. तो म्यूटेशन तो सब में मिलेगी, लेकिन टारगेटेबल म्यूटेशन जिसके लिए हमारे पास टारगेट है, वो आइडेंटिफाई करना एंड देन ट्रीटिंग इट विद अ मेडिसिन इज कॉल्ड टारगेटेड अप्रोच. अब म्यूटेशन होने से दो चीजें खराब होती हैं कैंसर के केस में. या तो सरफेस ग्रोथ रिसेप्टर्स, सरफेस जो सेल की सरफेस पे हैं, या फिर इंट्रासेलुलर ग्रोथ रिसेप्टर डोमेन्स जिनको हम बोलते हैं टायरोसिन काइनेसिस, राइट? सो ग्रोथ फैक्टर एंड टायरोसिन काइनेसिस. ग्रोथ फैक्टर सरफेस के बाहर, टायरोसिन काइनेस सरफेस के अंदर. अब अगर सरफेस के बाहर का जो रिसेप्टर है वो हाइपर एक्टिव है तो सेल जल्दी ग्रो करेगा. उसको रोकने के लिए जो हम थेरेपी देते हैं, मोस्ट ऑफ देम आर मोनोक्लोनल एंटीबॉडीज. सेल सरफेस के ऊपर ग्रोथ फैक्टर के ऊपर जो काम करेगा वो एंटीबॉडी. सेल सरफेस के नीचे जो है वो है टायरोसिन काइनेसिस, और उसमें जो काम करेंगी वो करेंगी टायरोसिन काइनेस इनहिबिटर्स. टायरोसिन काइनेस इनहिबिटर्स जो होते हैं वो ओरल टैबलेट्स होती हैं, और मोनोक्लोनल एंटीबॉडीज जो हैं वो इंजेक्टेबल थेरेपीज होती हैं, राइट? सो दीज एंटीबॉडी है तो इट्स अ पार्ट ऑफ एन इम्यूनोथेरेपी. तो इम्यूनोथेरेपी आज की डेट में जो हम बहुत ज़्यादा बात करते हैं इम्यूनोथेरेपी, बेसिकली इम्यूनोथेरेपी वी आर यूजिंग इट सिंस डिकेड्स. बट आजकल जिन दवाइयों को हम स्पेसिफिकली इम्यूनोथेरेपी बोल रहे हैं they are immune checkpoint inhibitors. उनको हम स्पेसिफिकली इम्यूनोथेरेपी बोलते हैं, लेकिन अगर देखा जाए तो पुरानी जैसे रिटुक्सीमैब, राइट, बेसिजुमैब, ट्रास्टुजुमैब, अब ये एज ओल्ड हो गई, 2 डिकेड पुरानी हो गई हैं, ये भी सब एंटीबॉडीज ही हैं, एंड दे आर आल्सो एक्चुअली दे आर आल्सो पार्ट ऑफ इम्यूनोथेरेपी, राइट, एंड दे आर कैंसर स्पेसिफिक इम्यूनोथेरेपीज। आज जो हम इम्यूनोथेरेपी की बात करते हैं तो क्या कहते हैं, दे आर इम्यून बूस्टर्स, दे आर नॉट इम्यून बूस्टर्स, these immune cell, these antibodies work specifically against cancer cells. So ये जो हमारी antibodies हैं, ये ऐसा नहीं कि हम किसी को दे दिया तो उसकी जनरल immunity boost हो गई या वो so being addressing a team of doctors, I understand that हमें पता है कि antibodies are very specific for their targets. तो यहाँ पर जो है cancer specific antibodies हम use करते हैं. Now what are these immune checkpoint inhibitors? Basically हमारी body में जो immune cells हैं वो हमारी body के own cells. So they recognize their own cells by some proteins over the surface. If these surface proteins are present over the body, over a cell, then our own immune cells recognize it as they okay, ये अपना बनता है. जैसे हमारे पास समझ लो आधार कार्ड. So if I have an आधार कार्ड, so no, I can show it to an authority कि भैया मैं इंडियन हूँ, तो okay भाई, तू इंडियन है. So somebody who is not having an आधार कार्ड doing something wrong, तो उस पे suspicion जाएगा. उसी तरह हमारी बॉडी में जिनके ऊपर वो cells हैं, वो own cell है, बाकी जिनके नहीं है वो foreign cells हैं. So every day our body creates a lot of cancer cells और immune cells उनको recognize करते हैं because cancer cells generally do not harbor such आधार cards, right? उनके पास वो आधार कार्ड नहीं होता है and that is why हमारी body उनको खत्म कर देती है. But cancer cells are very smart. Those cancer cells who develop such proteins over their surfaces, they can evade immune reactions and then they may grow. और ये जो immunotherapy, जो immune checkpoint inhibitors हैं, they actually are, so we have multiple such proteins in our body, but it has been identified that 2 CTLA and PDL1, these are 2 specific proteins which are present over the tumor cells. और जब हम इनको टारगेट करते हैं, जब इनके आधार कार्ड उनसे ले लेते हैं, when we target, when we give antibodies against these proteins, it is something like taking Aadhaar card from a wrong person, right? अगर हम उनसे आधार ले लेते हैं, then the police can come. So our immune cells may, come there and actually kill these cells. We have got very good responses in a lot of tumors, but immunotherapy is not magic bullet. It is not something which is like a Sanjeevani booty. It is not 100% efficacious. If it works well, it works very good, right? We have seen complete responses and sustained responses in metastatic diseases. Now we are getting patients who are in complete remission, disease-free for years. So for 3 years, 5 years now. So these medicines are in use for last 10 years, and now we are getting patients who are surviving for more than 5 years now. Although the number are less, but yes, we do have such patients. So this is what I was telling about. If this whole is a population of non-small cell lung cancer patients, we have to do certain molecular analysis and we have to segregate them as per their molecular profile. For example, if the patient is having EGFR mutation, ALK mutation, KRAS, G12C, ROS, BRAF, MET, RET, NTRK, HER2, and NRG1. So basically we stratify these patients based on their molecular markers, and then we try to, so this patient, next slide. So this is how they are being treated. A patient harbors EGFR we have to give osimertinib, afatinib, gefitinib, erlotinib, right? Then alfusions, alectinib, crizotinib, brigatinib, logatinib, ROS, crizotinib. So some of these medicines are not even available in India, and now they are recommended first-line drugs. Now coming back to my previous thing again, a patient with say PET scans showing multiple metastases, right? And patient comes to me with an FNAC report, and say if it says adenocarcinoma, right? Now this patient would again need a biopsy, because unless and until I have a biopsy, I won't be able to do this sort of a molecular segregation, molecular profiling for the patient. These tests are very costly, these drugs are very costly, no doubt about it. But in another 5 to 10 years, most of these medicines are going to lose their patent, and they are going to be dirt cheap, and will be able to use it in vast majority of patients. But those patients who are getting these drugs, majority of these patients are showing very good responses. For example, EGFR and ALK, they are the most common molecular markers, molecular mutations that we see in our patients. And believe me, those who are EGFR and ALK positive, 80% of these patients are going to survive more than 5 years. More than 5 years. And it's a great achievement, because if I talk about 20 years back, having a metastatic CA lung, the survival used to be 6 months only. And now we are talking about 5 years and beyond. So this is my last slide. We have, if you get a very early stage tumor, right, lung cancer, say T1 disease, the standard of care used to be surgery. So the first thing that was the standard of care was a surgery. After that came an addition of adjuvant chemotherapy in those patients in which either the tumor size is more than 4 cm or there's an lymph node involved. Right? Though the benefit of the benefit that is written in our books is only 5% survival, but that 5% survival is also substantial. It used to be very substantial, and we used to treat these patients. In the era of immunotherapy, now we are using immunotherapy even in early stages, right? In a perioperative setting, in few patients we give it before surgery, in few patients we give it after surgery, and in few patients we are giving in pre-operative as well as in post-operative setting, right? And so this is a Kaplan-Meier curve which shows that there was separation of survival, disease-free survival curve since from the beginning. If we add chemotherapy in post-operative setting, and this is so here the grey one is without chemotherapy and the yellow one is with chemotherapy. In the other chart, the grey one is the standard of care of now, that is the chemotherapy, versus the green one is immunotherapy. So we can see that since from the beginning, this graph actually starts separating. And this is how medical science evolves. This is how things get better over and over. When we add newer molecules, we get better survivals. You might be wondering that these, the gap between these are very less, but these graphs has to be studied in a different manner. Right? For example, first I drew this horizontal line. It is at 50%. So whenever we talk about disease-free survival or overall survival, we talk about 50% or median survival, right? Median survival is at the 50%. So I drew a 50% line, and then see, with chemotherapy the median survival was somewhere around 2.5 years. With the addition of chemotherapy, this median year survival is somewhere around 3.25 to 3.5 years. So if we add chemotherapy, we are actually adding 1 year of life in more than 50% of the patients, because the 50% of patients are going to cross this time duration. So when I say median, that means 50% of them are going to cross this period. And when we talk about immunotherapy, so it was 2.5 years, 3.5 years, and here it is almost 5 years. Right? So these graphs might look very close to each other, but when we study these graphs, we have to study in such a manner so that it makes sense. Right? And being medical professionals, we need to understand that this is how science evolves. We cannot just, today we have a survival of 10 and we cannot expect to have a drug which will have a survival of 90 from tomorrow, right? So from 10 we'll go to 20, then we'll go to 30, and today if you see the 5-year survival, 50% are going to have a 5 year of survival. This is wonderful response. Right? Yeah, so this was my last slide.
Okay, great.
Thank you.
बेटा लाइट ऑन कर दे, लाइट ऑन कर दो.
Dr. Well, thank you for a wonderful deliberation. आप इधर आ जाओ please. We can.
बेटा ये बंद करना.
So for me the first message is that if I have a solid tumor oncology issue, I must refer that case to you. सबसे ज़्यादा इम्पोर्टेंट चीज़ तो मेरे लिए ये है. मैं आपसे ये जानना चाह रहा था, आपने तो खैर डॉक्टर तुलसी की इंसिस्टेंस पे ये पल्मोनोलॉजी वाले दिखाए, he wanted a specific thing. I'm sure you are treating lymphoma also.
So I'm treating solid tumors only. But if you have any query for lymphoma, I may address that.
No. What?
So I used to. Solid tumors means anything non-hematological. Anything non-hematological, which includes lymphomas, leukemias, myelomas.
You are not treating those?
No, I am not treating. We have a dedicated hematology team. So our hematology team is basically, we have segregated our work.
तुम्हारी सबसे ज़्यादा फोटो आई है इसके अंदर, तुम्हारी सबसे ज़्यादा फोटो आई है इसके अंदर, आगे से
past 3 years I am not treating.
Are you treating neuroblastomas?
Pediatric tumors not.
You are also not treating neuroblastomas.
So, pediatric oncology is a separate branch, hemato-oncology is a separate branch, and medical oncology is a separate branch.
Alright. So now coming to the pulmonary tumors, traditionally we've been told small cell and non-small cell, and now there has been a redefinition of those tumors.
Yes.
So I would like to know from you, we were told that I believe small cell carcinoma has a better prognosis? No, it is the other way around. Alright. So what do we call non-small cell carcinomas these days? What do we call them?
Non-small cell classification is still there, but they have to be further sub-classified. Whether it is adenocarcinoma or squamous cell carcinoma. If they are adenocarcinomas, whether they are harboring any molecular mutations or not, right? If not, then whether they are PD-L1 positive or not. Because based on the PD-L1 report, so percentage positivity of the PD-L1, we are going to decide whether this patient is going to get benefit from immunotherapy alone, or whether this patient is going to get benefits from chemotherapy in combination with chemotherapy.
So the traditional teaching has been that squamous cell carcinomas are more sensitive to radiotherapy, small and adenocarcinomas are more sensitive to chemotherapy. Does that hold true today also?
It all depends on the stage of the disease, right? So for example, early stage adenocarcinoma will be better than late stage carcinoma.
Early stage adenocarcinoma, they will be better off with chemo or with radio?
Early in thoracic oncology.
Yes.
So for early stage surgery is still preferred.
I am talking about chemo versus radio.
Chemo versus radio.
Yes.
Both has to be given.
Both have to be
Chemo
and squamous?
Same.
Same.
Yes.
Right. Now coming to the specific question of immunotherapy, and that was the thing Dr. Tulsi was, I believe, insisting upon. and it has changed the prognosis of even stage 4 carcinoma.
Yes.
In your own experience, which cancers in lungs are best targeted by immunotherapy to change prognosis and longevity beyond 5 years?
So right now, almost all the patients are candidates for immunotherapy treatment, whether they are early stage or whether they are intermediate stage, that is stage 3, or whether they are stage 4 patients.
So let us say I bring my question to stage 4 carcinomas. How are we changing the prognosis in stage 4 pulmonary carcinomas with immunotherapy?
So immunotherapies are effective on those patients which do not harbor any molecular targets like EGFR, ALK or ROS. If these targets are present, then it is 100% certain that immunotherapy is not going to work in these patients. And we prefer giving targeted therapies to these patients over immunotherapy. Right. Even in second line and third line, immunotherapies are tried sometime, but generally they do not respond.
Right. I would also like to know you the cost of immunotherapy in your setup and how long do we need to treat, how many cycles?
Okay, so right now, a month back, first biosimilar has been launched in India. Earlier than that, all the molecules of immunotherapy, they were patented molecules. They cost varies from 2.5 lakh rupees so, per dose. It used to be like 2.5 to 5 lakh rupees per dose, but now with our first generation nivolumab, the cost has come down to 50,000 to 80,000 rupees per cycle. Though it is still costly, but company has came up with a patient assistance program, and under this program, patient will get this disease, will get this medicine for a cost of somewhere around 6.5 lakh rupees for entire year treatment.
There have also been talks of a scheme where they say that you get one cycle and then you get the next cycle free. Are they true?
So there are patient assistance program are designed like that only. So in some they get 1+1, in some they give you 2+1. In nivolumab, they have two sort of schemes. One is you take 2, you will get 2 free, right? And the other part of the scheme is that, or you can offer scheme B, which is like you have to buy first 9 doses, and the remaining 17 doses will be free.
All right. My last question, with permission from Dr. Tulsi sir, is the prognosis and treatment of pleural-based Ewing sarcoma.
Ewing sarcoma. Ewing sarcoma is a very notorious disease. Right? These patients are actually treated timely. So if we are talking about pleural-based means it is already metastatic.
Yes.
So for metastatic sarcoma, things are not very good. We can control the disease for a very longer time because now we have the capability to give high dose chemotherapies. But cure is certainly not there. We can control the disease, but overall prognosis is good.
Thank you, Dr. Mayank. I think it's been wonderful interacting with you. I would like to give it to Dr. M.S. Gandhi for a question.
Immunotherapy reimbursable है by the insurance company or by under CGHS or other schemes?
So under earlier under CGHS, ECHS and all sort of government PSUs, it is basically DGCI approved medications. All these medications are DGCI approved, and DGCI approve only those medications which are FDA approved, right? So they are approved by all the panels. We are giving immunotherapy, especially in that most of the cash patients they are not able to afford it. And whatever experience we have with the immunotherapy, most of these patients are from CGHS, DGHS, ECHS, and these are reimbursed. In fact, nowadays even when we do not have the medicine, CGHS give the medicine to the patient and they fund it.
So what is the treatment of modernity for small cell carcinoma? Is there targeted therapy, immunotherapy?
So sir, it depends on the stage of the treatment. But the staging of small cell carcinoma is done in a different way. We call it as a limited stage disease or extensive stage disease. If it is a limited stage disease, we treat it with combination of.
Another question: what is the cause of resistance in the targeted therapy?
Sorry, sir.
What is the cause of resistance in targeted therapy? Because once we are doing this targeted therapy, thyrokinase inhibitor, it gets resistance. What are the causes of that resistance?
So if we remember, there used to be this signal pathways, right? ऊपर का receptor खराब हुआ, उसने नीचे को signal दिया, उसने नीचे को signal दिया. A problem क्या है? The emergence of new mutations, the emergence of new defective molecules actually causes resistance to this. For example, molecule A stimulates molecule B, and B, C, D, E, F all are normal. Only A is abnormal. अब A में लगातार stimulus दिए जा रहा है, तो नीचे वो डाउनस्ट्रीम सिग्नलिंग होती जाएगी. आपने A को इनहिबिट कर दिया, तो सिग्नलिंग रुक गई, राइट? बट नाउ C gets defective. आपने जो दवाई दी वो A के लिए है. अगर C नीचे का जो डाउनस्ट्रीम पाथवे में जो प्रोटीन है, अगर वो डिफेक्टिव हो गया, तो फिर क्या होगा? नीचे फिर सिग्नलिंग शुरू हो गई. अब वो दवाई A पे काम कर रही है. That is how it causes resistance to A. So इम्यूनोथेरेपी में भी सर, जैसे मैंने भी बताया कि जिनमें EGFR क्रॉस उसमें काम नहीं करता, लेकिन जिनमें काम कर रही है इम्यूनोथेरेपी, अगर उनमें आगे जाके कोई मॉलिक्यूलर म्यूटेशन, देयर आर सम मॉलिक्यूलर म्यूटेशंस जो अभी तक आइडेंटिफाई करी जा चुकी हैं कि उसमें इम्यूनोथेरेपी पे रेजिस्टेंस आ जाता है.
Dr. Mayank, very nice talk. One question and one comment, and then all for Dr. Tulsi and other friends. My comment is that targeted treatment is just like yogi model. Yogi model.
What is yogi model?
Bulldozer model. You identify the persons who are the miscreants and
Absolutely.
treat them.
Yeah, so it sounds like that.
Yeah.
I do not know yogi model.
It is yogi model. You have to find the persons who are responsible for that mob action and
Yes.
go for them.
So targeted therapy, the name derives from itself.
Yeah.
We identify the target and then we treat it.
Sir, my one question is about, we were very much excited initially when we were students. FNAC हो गया, बस diagnosis हो गया. Now as you said, FNAC is hardly anything. It is fine means not fine. And
Sir,
we have to.
अभी भी हमारे लिए कहीं काम आती है.
And then came.
सच्ची बात हो तो FNAC हमारे लिए वहाँ काम आती है जहाँ पर it is not going to make any
Major problem.
treatment decision में कहीं help नहीं करेगी. But for our record purposes, we need some proof.
Yeah.
For example, patient of say head and neck cancer treated with surgery, then CTRT, and he has developed a nodule over a skin, saying within 6 months. You know, there are high chances that this would be malignancy. So getting a biopsy from there again is not going to give me any additional information. Even an FNAC positive is okay for me to go ahead because my treatment is not going to change.
Right. So after FNAC, next step was true cut, true biopsy,
or a punch biopsy,
or say excision biopsy. So what minimum is required for your molecular level testing? Because otherwise.
Even true cut biopsy is enough for us. Because those who are doing true cut biopsy, they also take multiple codes.
And liquid biopsy, does it
liquid biopsy is
convey something for you, or it is only for the?
Sir, liquid biopsy is very good, but the yield is very less. So it is something like there is a pleural effusion. You do a tap, and it says negative for malignant cells. It does not mean that there is no there would not be any malignancy. 3 FNACs are required. They all are negative. Then you are 90% sure that okay, malignancy might not be the cause of the pleural effusion. Similarly, liquid biopsy, if it comes positive, it will give you a lot of details. But if it comes negative, does not mean that tumor is not there.
Are there any biomarkers also coming up which can be replacing or say augmenting biopsy? Biomarkers in the blood. Any new biomarkers?
So they are liquid biopsies, and the biomarkers they're talking about is all these markers that we just discussed. So if you have a cancer cell floating in blood and you just if you just identify it, you'll be able to tell the surface proteins and intracellular mutations.
Wonderful, Dr. Mayank. Just last two comments from my moderators. Dr. Tulsi first.
So let us say, friends, that's an excellent talk by Dr. Mayank. So what we learned today was that you need to start targeted therapies early in the disease, as early as probably stage 0-1, instead of starting at stage 4. What do you say, sir?
So there are cases when they are used in early, and there are cases
preoperatively as well.
Yes.
And would prevent brain mets to other organs as well if you start early. Number 2, what we learned was that it's really important to diagnose CA lung very early. And how do you diagnose? If you have a family history, or if you've been a smoker, you need to get an LD CT done. Low dose CT scan to be done, and probably then followed up with that. Now the other thing was that in stage 3, there has been a paradigm shift in the way you treat these stage 3 diseases today. The hitherto unresectable disease in stage 3 is today resectable. At least 70 to 80% of unresectable disease in the past is resectable today. So stage 3 also has a good prognosis today. My final thing would be regarding the cancer vaccine, the lung cancer vaccine. We know 2 vaccines are coming. They are in stage 1. One is for prevention. See, patients who have been a smoker or have family history of lung cancer, if you give this lung vaccine, it will prevent lung cancer. The other is a therapeutic, or the treatment for lung cancer to relapse, not to have relapse of this. How much about the lung vaccine, cancer lung vaccine?
So basically, it's not just lung vaccine, vaccination, and these are basically. So you must have heard about CAR T cell therapies, right? What we do is that we identify the cancer antigen. We try to create antibodies against that particular antigen, and in the lab, right? We create that antibodies in the lab, and then we install it in the patient's body, so that it can actually target the very specific protein, which is very unique for that patient, right? And these vaccines are also such vaccines. They will be patient specific. They are not just going to be like HPV vaccine, but they are going to be more patient specific. So as I said earlier, we already had immunotherapies in past, but a subset of subset of drugs are getting famous with the name of immunotherapy. Similarly, the concept of this vaccine, right, the CAR T cell, the chimeric cell therapy. So we already have such vaccine for prostate cancer, Cipollicity, right? We do not have much of scientific data whether they are going to actually work or not. So I am very positive that I think in future vaccination and more importantly gut microbiome. Yes, so एक मैं थोड़ा सा out of context में बात करूँगा. I would like to tell every one of you, please limit use of pantoprazole, esomeprazole, rabiprazole. These are actually they are doing a massive problem or destruction to our normal gut microbiome. And research, we are getting a lot of papers on gut microbiome, and a lot of diseases, not just cancer, but a lot of diseases are emerging because of not just liver disease, heart disease, psychiatric disorders, cancers, and they are actually, so in patients who are getting immunotherapy, we do not prescribe pantoprazole. Patients who are getting targeted therapy, we do not prescribe pantoprazole. They are contraindicated medications. So right now in my clinical practice, I stopped using prazoles in all my patients because they negatively impact your gut microbiome and even the patient's healing capacity and patients. So the papers are there, and it's not just my hypothesis. So we are getting papers, although the phase 3 and phase 4 trials are underway, but we are having very good, we are getting a lot of data, scientific data. that altering these gut microbiomes actually are going to make a huge impact. So in future, I think a lot of work is going on in the field of vaccination as well as in the field of changing the gut microbiome.
Dr. Pawan Chaudhary has a question.
Just one small question, sir. The role of chemotherapy or immunotherapy in the CNS lymphomas or high-grade gliomas?
So in CNS lymphomas, chemotherapy has a very major role, right? Because the high-dose methotrexate, cytarabine, vincristine that we give in these. So for example, methotrexate, right? We give high-dose methotrexate in CNS lymphomas. We get very good responses, right? And with the addition of radiotherapy, right, we are getting long-term survival. As far as gliomas are concerned, you asked me about high-grade gliomas. So temozolomide is a standard of care in treating high-grade gliomas. The role, so basically, see, in high-grade gliomas, the curative treatment is surgery. Right? If I get good surgery, if there is complete resection of the tumor, gross tumor resection, that is a GTR, then the survival is going to be much better versus those who are in which we are getting subtotal resections. And then whether we give chemotherapy, radiotherapy, that the entire prognosis depends on the extent of the resection. And chemotherapy, we have very limited chemotherapy options in second and third lines. We have a PCV regimen, we have irinotecan, and only a single target therapy, that is the best.
Thank you very much, Dr. Mayank. My last word from my moderator, Dr. Sunil Kapoor sir, and we wind it up.
It's been a lovely talk. It's been a lovely talk.
नहीं चल काम नहीं कर रहा
We've learned a lot. A newer angle, a newer aspect of immunotherapy has a very significant role. I myself have been on for the psoriasis on monoclonal antibodies, followed by I'm taking tyrosine inhibitors now. Another thing is do these things induce cancer? Because I got basal cell carcinoma monoclonal antibodies. Very painful.
No sir, that is not so. The side effect profile of immunotherapy, I haven't read that basal cell carcinoma is a part of that. Though rare and phase 4 and 5 things might come up, but it is not that common to have a basal cell carcinoma with the immunotherapy.
Thank you so much. Thank you for a wonderful talk.
Thanks a lot, Venkateshwara. Thanks a lot, Vikas. I'm extremely grateful to all of you. I request Dr. Mayank to please have his dinner, and all of you also to have his dinner.